My name is Dr. Amir. Good morning, I guess, to everybody. It's about 3 p.m., 3:30 p.m. here actually in Malaysia. Um, I'll be discussing a bit on the scoliosis here share about my work regarding scoliosis. So I have nothing to disclose. But before I begin, probably share with you where Malaysia is actually. Malaysia is a small country located at the southeast of Asia, and we are multiracial. We have Malaysians, we've got Malays, we've got Indians and Chinese, and we live together. And it is a mix of heritage and also advancements and industries in Malaysia. A lot of modernization. It's a nice, beautiful country. We have about 34 to 35 million people, and statistics here shows that we have about 2 to 3% of scoliosis population in Malaysia, about 600 to 900,000, in which 2.5% of them are actually belonging to the idiopathic group, about 15,000 to 22,500, but only 0.1% of them actually need surgery. So Malaysia itself is divided into two. We have East Malaysia and also West Malaysia, divided by the South China Sea. And if you look at this map, these are actually the centers for scoliosis in Malaysia. If in Malaysia, the healthcare system is divided into public, private hospitals, and also university hospitals. However, for public hospitals, there's only a handful of them. And I am located in one of the public hospital, government hospital here nearby the capital city of Kuala Lumpur. And my hospital is Hospital Sungai Buloh. And we do roughly about 50 scoliosis cases per year. So how do we get these patients? Well, in Malaysia, we have a school scoliosis screening program since 2005 by the Ministry of Health. And this program focuses on students at the age of 12 years old. It is an inexpensive program run by the doctors and nurses, and they just do a Adam forward bending test, and also they look at the rib hump, and a positive Adam bending test, and or positive or more of a 5 degree of angle of trunk rotation, then these patients will then be sent to hospital tertiary center. So there are a few papers already discussing regarding the effectiveness or the significance of a school scoliosis program in Malaysia, and from then on, it seems to be very, very reliable, because we will manage to detect more than 50% of scoliosis patients from school-going children, also called as predictive positive value. So this is a good screening tool, and it is something that is ongoing currently. As you all know, there are multiple causes for scoliosis. There's idiopathic, congenital, developmental, neuromuscular, and also tumor associated. However, what we are going to share today are mostly regarding the adolescent idiopathic group. Okay, this is a guideline for treatment for scoliosis. I think if you look at the arrow there, I think we are aware that treatment for scoliosis does not solely depend on the magnitude of the curve, but also on the growth potential of the patient. The younger the patient, the higher risk for progression. As you can see, majority of patients actually fall into the observation and also the non-surgical treatment group. Okay, so either you observe or you apply them bracing or send them for physiotherapy for muscle strengthening. But only a few would actually fall into the surgical category, and these are mostly patients above 50 degrees of curve, or those with higher risk of progression. For example, uh, young patients, patients who are non-compliant with brace, patients with rapid progression of a curve. Then these are evaluated and given options for surgery. Lenke has come out with a very good classification to replace the previous King's classification. So Lenke classification is more of a 3D classification, and he has 6 types altogether. And type 1 is mainly regarding the main thoracic curve. Type 2 is about curve which are double thoracic. Type 3 are double major curves. Type 4 are triple major. Type 5 are practically lumbar curves. And type 6 are actually lumbar with main thoracic curves. All right, so these are lumbar types of lumbar curves identified by Lenke. But I want to bring your attention to these modifiers as well. Lenke has also described 3 types of lumbar spine modifier. These are based on the CSVL, or the center sacral vertical line, in which if it falls in between the pedicle, then that is called as a lumbar spine modifier A. If it touches the apical body, then it will be type B, or if it is completely off or completely medial, then it will be type C. All right. Um, I mean, before I proceed, I think it's also good to actually recap back the radiographic parameters, especially when we are looking at scoliosis radiographs. There are a few things that we should recognize. For example, one is neutral vertebrae. So neutral vertebrae are the first non-rotated vertebrae located either at the cranial or the caudal end. Okay, and we should also know about end vertebrae. Now, the end vertebrae, also located at the cranial or caudal end, are the vertebrae that is least rotated and least horizontally displaced. So it's just about to get to normal. And the apical vertebra. So this is self-explanatory. This is the vertebra which is the most rotated or most horizontally displaced. And there's also a thing called stable vertebra. The stable vertebra is the vertebra which is bisected by the CSVL. And then you have your curves. You have your major curves, which is, when you look at the radiographs, you see the one with the biggest curve that is called the major curve. And the one with a smaller curve, we call that as a minor curve. And this minor curve usually is located, above or below the major curve. And its role is usually to compensate or to maintain the body balance. And of course, we need to know how to measure the Cobb angle. And the Cobb angle are actually 2 lines drawn from the upper end plate of the uppermost vertebrae in the curve, and the lowermost vertebrae, the inferior end plate of the lowermost vertebrae, which is located in the curve. Then you can get the Cobb angle itself. All right. Apart from that, there is also a C7 plumb line. So a C7 plumb line is just a line, a vertical line drawn from your C7, and which drops down. Then you can see in this illustration, which drops down. That would be the C7 plumb line. And you also have your CSVL, as I mentioned earlier, which is a vertical line bisecting the center of the sacrum, and it is perpendicular to the iliac crest. Okay, so there's 2 lines here. So a good line would be a balanced spine, would mean the C7 plumb line and the CSVL would actually be parallel, right? But if there are discrepancy, then this would be called as coronal malalignment. Okay, that would be the distance between the C7 plumb line and the CSVL itself. As I mentioned earlier, scoliosis is a 3D deformity, right? So you would have rotation, displacement of the rib hump, and once this is displaced, you can also have reduce in the lung volume. All right. So in order for us to do surgery, we also need to first to determine the level of fusion. So then comes the term of UIV, or the upper instrumented vertebrae. So the upper instrumented vertebrae refers to the highest level of instrumented vertebrae, and that is where we will stop our fusion level. And this location is solely depends on the curve type and shoulder balance. So it can actually, it's not fixed, but it really depends on the curve type. For example, in type 1, for example, where you have a thoracic curve, if the shoulders are balanced, then you would likely stop at T3. If the shoulders are in balance, whereby the right side is higher, then we probably stop at T4. And if it is left side shoulder is high, then we probably start at T2. So these are the UIV, examples of UIV. There's another thing called LIV, which is the lower instrumented vertebra, and this is the lowermost level that you want to fuse. And the location of this LIV is usually located at the most stable vertebra. Sometimes it can go one level or two levels above the stable vertebra, depending on the flexibility of the vertebra itself. So my talk is regarding fusion of the spine. So the traditionally Harrington introduced the Harrington technique for correction and deformity and fusion of the spine. So what Harrington does, he introduces distraction on the concave side and compression on the convex side. This is good, but at the same time, it does not correct the rotational deformity. It corrects the lateral displacement, but the rotational deformity is not corrected. So at the same time, the rod itself is very straight in Harrington rod. So at the end of the day, patient would most likely have like a flat back, and still the hump is still visible. So the Harrington technique was popular, but it has its some setbacks. Then Professor Luke came with his cable and wire techniques. This also was to translate the vertebra which is laterally displaced. The technique was fine for flexible curves. However, it was not so suitable for very rigid or very stiff curves, and with using cables and wires, it was not mechanically stable, as you can get wire breakage or maybe the cable failure. So this was traditionally done and also not done anymore. But what's more common now are the Cottrell and Dubusse approach. So what Cottrell and Dubusse, with the introduction of pedicle screws, they use this as an advantage. With the pedicle screws and the rod is able to derotate the spine, and by derotating the spine, you can correct the lateral deformity and also the hump, right? So Cottrell-Dubusse's technique is much more widely used nowadays. So as an example in this illustration, once you put in the pedicle screws, you put in the rod at the concave side, and the rod will then you will then derotate the rod, and you will correct. You will get a correction, deformity correction. Um, okay, let me see if I can play this. Okay, so I got this from the internet. It's just a simple illustration. As you can see here, yeah, they're looking for the pedicle landmarks, measuring the pedicle length, right? Yeah, this looks like doing a funneling technique of the pedicle screw incision, tapping the pedicle, and afterwards inserting the pedicle screws. So, like this, all the pedicle screws are placed, and the rod is bent according to the curve and applied on the concave side. And once that is done, it is derotated and the deformity is corrected. Right? So this is a very simple illustration on how a controlled Debussy technique is. But definitely there are different techniques as well. There are inside to bending, there are cantilever techniques, there are also posteromedial translation. These are all surgical techniques to uh, for rod placement and deformity correction, which can be used concurrently with the other methods as well. Um, but what I have discussed earlier are very, very feasible for flexible curves because they are flexible. So you are able to rotate them and you are able to correct them easier. But if you look at these kind of radiographs, these are very big magnitude curves and these are rigid curves, all right? And definitely a simple derotation like that will not work. So what would be the strategies for these kind of cases? So for very rigid cases, I would apply them with halo traction. I would apply them for halo traction for at least about a month. I would admit them in the ward and apply them with halo, and they will be the skull will be tracked for nearly a month. All right, this would help in the soft tissue relaxation, so that would be makes it easier, and also to reduce the magnitude of the curve. I would also think whether to do a just a posterior spinal instrumentation alone, or would I need to do a posterior column osteotomy as well? For example, like Ponte osteotomy or Smith-Peterson osteotomy. That is something that I would think about. I would also think whether I would need to do an anterior release. Uh, we probably go and do a discectomy, put interbody cages in between to release the anterior ligaments, anterior structures in front. Um, or I would also think whether to do 3-column osteotomies, but these are quite aggressive, as this procedure can cause a lot of bleeding and can also cause a neurological deficit, especially in patients with severe curves. They already have a poor lung function. So these are things that I would consider, but whether it's necessary or not. And lastly is the triple rod technique I want to introduce to everyone here. So a triple rod technique is actually an advanced spinal instrumentation method for correcting severe and rigid scoliosis, and it involves the sequential placements of 3 rods, not 2 rods, but 3 rods, to enhance the deformity correction, reduce mechanical stress on the rods, and improve the stability of the construct. So I give you an illustration here. You have a big curve like this, and then I would put the pedicle screws at the around the concave and the convex side at the apical and periapical region, and I would put shorter rod in the concave side first, and this rod will then be distracted gradually. All right. So gradual distraction of the rod would definitely reduce the magnitude of the curve. This is coupled by your facetectomy and also your soft tissue releases. This will definitely reduce the magnitude of the curve. And once you have achieved what is necessary, then you would put your second rod on the concave side as well to bridge it, and you would then complement it on the convex side. So this will be a 3-rod construct, right? So this technique has been done in many countries, and so far the rate of correction is very good, where in which you can get more than 50% correction. As like this paper, you can get about 53% of correction. In this paper, um, they had about 50% correction as well. And another paper published in the Journal of Neurosurgical Spine, they also got about 55% correction. So we also have our own case series. So we have about this is for the previous years. We had about 8 patients altogether, and these are not all adolescent idiopathic. They were also early onset. There were some syndromic. There were also neuromuscular scoliosis. But these patients had a very big and large curves. And as you can see, the average curves of these patients were about 98 degrees, but post-operatively managed to reduce to about 51 degrees, in which the correction rate was about 47%. And even the kyphosis also, we were able to reduce from 53.9 degrees to 35.2 degrees, with the correction rate of 34.6%. And the thoracolumbar region correction rate was about 53%. Okay, so when we talk about rigidity, what it means is any curve which are usually more than 90 degrees. All right, and these curves are they are not flexible, which they have a flexibility index of less than 25%. Okay, and the etiologies can vary. It can be idiopathic, congenital, neuromuscular, or syndromic. So a few case examples. We have these cases of starting off at about 96 degrees pre-operatively, but with this 3-rod technique, we managed to reduce it to 45%. And then even the kyphosis also improved from 78 degrees to 49 degrees. Another case example here, about 105 degrees, and we managed to reduce to about 66 degrees. And even the kyphosis also markedly reduced from 71 degrees to 33 degrees. And this is just a recent case in which me and Professor Jawid, we did together about 2 weeks ago. This boy, about 14 years old. He was admitted a month earlier than surgery. As you can see, we have applied the skull traction there, and he was on skull halo traction for 1 month altogether. He has a quite severe deformity. As you can see, he has got a shoulder imbalance, the huge rib hump, the rib cage are also deformed. The pelvis are also imbalanced. This boy is special because he has followed up under us since 2014. At that time, it was only about 28 degrees. Even though with bracing, the curve kept on progressing. And in this year, the family decided to have agreed for op. But by the time that we were about to do, it was nearly 150 degrees. But with a halo traction, soft tissue release, uh, and facetectomy, a lot of bone release, bone work, and also a three rod construct, we were able to reduce the curve more than 50 degrees, as you can see here in the photo. So this is an intra-op photo taken by Professor Javed himself. And these will be the clinical photos of him before op and also after op. Okay, so he will be seeing me soon in about 2 weeks' time, and probably I can update on the clinical photos later. So the three rod techniques, I think it is very useful. So it is a short rod applied at the apical region, which allows reduction of the coronal deformity via translation. And this is achieved by further rotation and distraction. You don't have to do too much of pre-bending of the long rod. And with the three rod construct, you reduce the risk of screw pull out. You also reduce the operative time, the operative blood loss, the likelihood of neurological complication, and also the occurrences of non-union or pseudoarthrosis, in which you commonly see when you do osteotomy, such as the posterior column osteotomy. So my end slide would be the conclusion. I would just like to say that managing scoliosis, either non-operative or operative, is rather challenging and requires patience and long-term follow-up. There are definitely multiple techniques available for deformity correction surgery, but the triple rock technique, I think, is an effective and safe method, especially for correction of rigid scoliosis. So with that, I thank you.
I just put up this one for Afghanistan. What do you think basically for the starter of scoliosis programs in those sort of countries with less resources? What a little bit, if you tell in short, like how they're going to start, from where to start, if you're putting a scoliosis program? Then we take a question.
Yeah, I think scoliosis screening program is very effective. I think you can look from the papers that has been published in Malaysia itself. The earliest school screening program was started all the way in America in the 1940s, and it has grown all over the world already. This screening method is very, very useful for us to pick them up and to prevent. And the earlier you pick up, the earlier you can manage them. I think countries like Afghanistan are capable of doing this. You just need trained doctors and nurses. The tests are very, very simple. All you need to do the Adams forward bending test, and you need a scoliometer. That's it. You just need a scoliometer to measure the rib hump. And you focus this test to children which are around the adolescent group, 12 years old, 13 years old. And once you pick them up, once these children are picked up, refer them to a tertiary center where they can do proper radiographs and proper observation or management. I think it is something to think about to start in Afghanistan if it hasn't started yet. I really, really recommend it.
Thank you. Great. So I think we're going to take up questions. If anyone have a questions, especially from our orthopedic, spine surgeon sites, neurosurgeons, just raise your hand. We're going to pick you up, and you can ask your question.
Yeah, thank you. Thank you, Professor Amir. Excellent lecture. I am neurosurgeon, but now I see a good overview, all the angles, how to correct that. Very nice. Thank you very much. We can use that, of course, for our country. As Dr. Javed said, he is excellent neurosurgeon, as you know, of course. In our condition, we have many patients with tuberculosis, TBC. And they get, of course, all the alignment problem with gibbosity. Is the intervention in that case, of course, after treating the TBC itself, is the same to correct the angle, or we have to deal with other problem? Thank you.
Yeah. Thank you, doctor, for your question. All right. For infection TB, spondylitis, actually, the scoliosis that occurs are mostly angular deformity. These are not global deformity like you see in scoliosis. These are the scoliosis. The TB would affect only a portion of the spine, which causes gibbous. So management for these patients after TB anti-TB is completed depends on the neurological status of the patient. If patients does not have any neurology, it's not advocated to do any deformity corrections in these patients. You can just let them heal, but let them heal because TB heals very, very well. Only a small portion of patients with TB has neurological deformity. And once that is, in my approach, once that is present, I will also do surgery to correct the deformity at the same time. But the aggressiveness of the surgery will not be as aggressive as the scoliosis because it's angular, so the construct would be shorter. Sometimes I would do a corpectomy, remove the whole anterior body, and reconstruct from the front only. No need to actually go from the back. So that's how I approach TB spine.
Any other questions from our orthopedic spine surgeon sides? What's the challenges in Afghanistan? Anyone want to
yes,
add
sir.
on?
I have a question, sir. After the triple rod fixation, after how long time we can correct the deformity and reduce the deformity, and how much we can correct the deformity? This was my.
Oh, regarding the time, you mean? Regarding the time? Once when you do a rigid curve, the key is actually to reduce the soft tissue and do a bit of bone work. You need to do facetectomy, remove the posterior ligamentous complex, the interspinous ligament, and so on, and make it less rigid or more mobile. Then only you insert your rod. Once you insert your rod and you start to distract, you can already see the movement of the curve. All right, you can already see the movement of the curve. You would always need to do this under intraoperative neuromonitoring because you do not want any signal to drop during this procedure. Once you feel that you have achieved maximum distraction, then you will lock it, and then you can immediately put your second rod at the cranial and at the caudal. You can immediately lock it straight away because there's no need to distract or no need to do any correction deformity anymore. So I hope that answers your question.
Yes. Burhani Sab, yeah, I think you can.
Yeah, thank you for giving me the chance to ask again. Dr. Amir, how about the adaptive form of scoliosis correction? As I see, sometimes it is difficult, but also maybe damaging some neurological structures to do at once. Are there other techniques that you do gradually within 1, 2, 3 months? Do you have any experience with that system? Thank you.
Right. Okay. Thank you for the question. I think nowadays, with the advancements of surgery, there are two big categories of scoliosis treatment. One is fusion, in which I have explained. The other one is actually growth modulation. For example, as vertebral body tethering, growing rods, and so on. For the for the surgery itself, surgical fusion, it is associated with a higher risk of neurological deficit. Most surgeries for surgical fusion are done nowadays by single stage, no longer by 2-stage or 3 stages for surgical fusion. And most of them has good result from surgical fusion, but the risk of neurology are still there. However, for growth modulation surgery, for example, like vertebral body tethering or growing rods, these surgeries are done are done multiple times. For example, growing rod are probably done maybe 3 to 6 times, perhaps, to ensure the length of the rod. VBT as well can also be done in 1 or 2 sittings. And these surgeries, growth modulations, are treated with a lesser risk of neurological injury. I have no experience in the growth modulation. In public hospitals, the resources that we have are limited, and we don't have the resources for the growth modulation. But perhaps if you were to explore regarding it in Afghanistan, maybe that would be a good option as well.
So let me ask a question which is coming into my mind.
Okay.
Dr. Amir, so the whole presentation was really amazing. So you had a very fantastic results. So the question is like, what about the long-term outcome of these kinds of surgeries, like in terms of quality of life and also in terms of functional outcome? This is the first part of the question. And the second is, what is the common complications which you see during the triple rod techniques surgeries?
All right, thank you for your question, Dr. Rashad. Okay, I'll answer the second question first. For the triple rod technique, so far, we have done probably maybe more than 10 cases so far. We have not encountered any complications yet. The most common complication that we have are actually bleeding, which are common in any long duration surgery. But we don't have any neurological deficit, or we don't have any drop in signal during the surgery. So far, everything has been, alhamdulillah, so far so good. So we are confident in doing the surgery, except the bleeding. But for the bleeding itself, we since the patient is in the ward for 1 month, what we do is we pre-operatively prepare the patient. We give them IV iron for the patient to build their HP before op, so that would reduce. We also prepare intraoperatively with cell saver or autologous blood transfusion. So this will also reduce the blood transfusion. But apart from that, so far, alhamdulillah, it's okay. For the second question, for the functional outcome, we look at functional outcomes in 2 for scoliosis surgery. One is the disability score itself for the spine. There are reduced in range of motion in patients who are having spinal fusion. However, this does not deter them from doing normal daily activities. They can still go to school as usual. They can still have families as usual. However, they would have a reduce in range of motion. In Muslim patients, they have a bit of a lack of range of motion, especially when they are doing their prayers on sujud. But all that can be trained with physiotherapy, and most of them can actually perform prayers as usual. Another way of looking at functional is regarding their self-esteem. Many patients after the surgery, if we correct their shoulder and pelvis and make it balanced, their self-esteem will improve. So functionally, they become more confident in themselves, and this is what we want in our generation. We have one a particular scoliosis patient in Malaysia. Was not done by me, but it was done by many years ago by another center. And after her fusion scoliosis surgery, she actually went on and represented Malaysia playing for the Olympics in wushu. So, yeah, in wushu. So that means that pretty much flexible, even though she has undergone scoliosis fusion.
Thanks, Dr. Amir, for your excellent presentation. It was effective for us. I have a question regarding to this case. Those patients which have already have neurological deficit due to scoliosis, is it possible to recover their neurological deficit after deformity surgery? Thanks.
All right. Thank you. From my patients that I have, the neurological deficit that happens in patients are not solely due to the deformity of the spine. Most of the patients who have neurology actually has a cord anomaly as well. Most commonly are syringomyelia. So these patients develop scoliosis secondary to syringomyelia. So if the patient has neurological deficit and scoliosis, whether the scoliosis can return back their neurological function, that is very tough question. I think you all as neurosurgeons are very well know this much better on treatment of syringomyelia. In my way of treatment, I would ask the neurosurgeon to treat the syringomyelia first. Only then we correct the deformity. So I hope that answers your question.
In eastern region of Afghanistan, we face some challenge about scoliosis when we have these patients. We don't have any expert anesthesia team to control our patient. And also, one of the most challenges, instruments are not available in eastern Afghanistan and Kabul. These are
the major challenge.
Yeah.
Yes.
Yeah. What's the role of anesthesia actually in scoliosis surgery? Actually, how much?
Sorry.
What's the role of anesthetist or anesthesiology in
Oh yeah, I think it is very vital to have an anesthetic team. Very vital. The reason being is that these patients who are undergoing scoliosis surgery, they would need to be under mild. They can't be under deep sedation. They must be under mild sedation. So they usually use TIVA, because we need to monitor the function of the nerve at the same time. Secondly, the anesthesia is very important to maintain the blood pressure. We do our surgery with a MAP of 70 and below to prevent blood loss. So we need a good anesthetist that can give us enough vasodilators to prevent this from to prevent further blood loss. So it's very vital. Alhamdulillah, in my hospital we have a dedicated spine anesthetist. So I think if you were all to embark on doing spine surgery or scoliosis surgery, you need to have a team, not just surgeons. You need to have anesthetists in the team as well.
So
can I ask a question?
Yeah, sure.
What would be the common cases in Afghanistan then? Are they trauma or infection, or are they tumors or?
Yeah. Dr. Shirjan, go ahead. I think if you want to ask, or if someone else, Dr. Abrahullah, I mean, what kind of case you have in Afghanistan commonly for spine?
We have a major case of trauma, like cervical, dorsal, lumbar spine fractures. It easily perform surgeries and governmental and private hospitals. Also, spend tumors in government hospital and private hospital. This is a challenge that closing correcting surgery is not available for.
And what about the infection? Infection, do you have a lot of TBs?
Yes.
You have a lot of TB, tuberculosis as well?
Yes, 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 sir. Yes, sir. There is in eastern region of Afghanistan, especially Nuristan province, Lagman province, we have TB cases.
All right, because Shirjan is in eastern Afghanistan. He's doing on this side. If you want to look on the other side of Afghanistan, I think as I'm in contact with them and they're referring a case, we consult everything. As he said, because this is a pine tree and mostly the season will come, it's at the top of the mountain. This is the trees like so beautiful at the top of the mountain. People go and pluck by hand. In that season, a lot of people will fall from the trees and come with that's with the lumbar fracture. Actually, this pine tree that the جلغوزي په وخت کې زما خلک کیسونه زیاتېږي نه
دا چې کله استاد وړه شي تر نه پورې د خلک بامونو ته خېږي دلته زیات تاخونو کې ژوند نه کوي بام کې اوسېږي که نه تر ماخوستن بام ته خېږي غورځېږي بیا خوب کې روانېږي بیا غورځېږي او چې سهار شي دا د میوو موسمي ونو ته خېږي نو دا د ټروما کیسونه ډېر زیات دي
Dr. Amir, it's also a suggestion, a humble suggestion, to form a scoliosis group, if you agree about that, just abroad and also inside the country specialists, because already we have made a great group of cardiac surgeons in Afghanistan over the whole world. They are helping. And next to that is a cancer care group also. So we saw a great success. So, and now we discuss all the cases before the operation and of course after the operation. And as you know, Afghanistan is a big country, many provinces, one of our good colleague in Eastern Afghanistan. And we want to communicate all the centers with each other and facilitate them. Of course, we have very little resources, but we have to try that. This is we should do that. If you want, we can also form an orthopedic and neurosurgical team just to discuss the complex cases and afterwards have some discussion, and maybe this pave the way for publication and research in the future. Just a suggestion.
I leave it.
Yeah, that's a very, very good suggestion. I'm okay. I'm willing to impart anything that I can help in this spine work. I don't really mind. We can make a group. We can make a discussion site. I'm okay. No problem at all.
Thank you very much.
Salam to everyone. I am Mahmoud Ali, the third-year resident of neurosurgery.
All right.
As Fabipur mentioned that in eastern area, there are many cases of fall down. So in Kandahar, as the southern area of Afghanistan there are many cases and plenty of the traumatic spine injuries, especially from fall downs, and many of the RTS road traffic accidents. There are many. And also we have a number of cases of spine infections, especially from the spine TBs. And we have many cases we have performed there, and we have the good result of the patients in this region.
Thank you, Dr. Sabali. So I think in southern Kandahar side as well, they're saying there's a lot of traumas and infections. So, Mr. Amir, you want to say some few words? If you have some things, then I think we're at the end of the program. I think we're just going to wrap it up.
Yeah. Well, I must say I thank you for the organizing committee. Thank you, Professor Jawid, for inviting me to share part of my work. I hope this sharing does not end here. We can definitely further on with this sharing. We can discuss things on how to improve our system. I think Afghanistan and Malaysia is not far off. We are also limited in resources. We're not so advanced as using robotics and all that yet. So I think it is something that we can work together towards the betterment of of spine. We share. I think our cases are also would probably be about the same. We've got a lot of trauma cases as well here in Malaysia, and we need to keep on discussing because the spine keeps on evolving every time, and we with discussions like this, it can definitely make us know what is recent and all. Yeah.
Thank you very much. So with that, I think I'm just going to close the sessions. And once again, I just really profound from my bottom of heart, thank you, Mr. Amir, to coming to just present. It's excellent topics. I have learned a lot. And I'm sure there was plenty of groups from Malaysia. I mean, like there's a lot of students, residents from here as well as from Afghanistan, Canada, Netherlands, and there's a lot of surgeons, and we stream it up. We have learned a lot from your today's presentations. Thank you very much. I hope we can keep this kind of collaboration in the future as well. And I thank all of you to come for today's program. So just with that, thank you very much. And we're just going to thank you. Alaikum salam. Thanks.